Tate Chronicles now transmitting.
Welcome to the Tate Chronicles on Healthcare Now Radio. And now, here's your host, Jim Tate.
Good day, citizens of the free world. From border to border, coast to coast, and to all the ships at sea, I bring you a warm welcome. This is your correspondent, Jim Tate, and thank you for tuning into the Tate Chronicles. Join me as we cut through the fog that exists at the leading edge of healthcare technology. Our mission is simple. We're searching for beneficial disruption in healthcare from emerging technology. I'm very pleased today. My guest is Dr. Jay Anders, who's the Chief Medical Officer at Medicomp Systems. Dr. Anders supports product development, serving as a representative and a voice for the physician and healthcare community that Medicomp's products serve. Prior to joining Medicomp, Dr. Anders served as the Chief Medical Officer for McKesson's Business Performance Services and was responsible for supporting development of clinical information systems for the organization. And so, first of all, Dr. Anders, thank you for your time and joining us this morning. I've been looking forward to this.
Thanks for having me, Jim.
You know, one reason I'm so glad to talk to you today is frequently I'm talking with people who are involved in healthcare technology. But I really like it when I can talk to somebody who's involved not only in the healthcare technology sphere, but also has a background being a provider, because often there's not enough overlap between those two things. Now, one thing I'm aware of is that I believe you attended recently in Washington, CMS had a program called Data at the Point of Care program. I think it may have even been hosted at the White House. Could you give us a little bit of background on that and what the outcome was? Well,
the whole program that CMS has been talking about is being able to fill in gaps in clinical information that providers could use via claims, and using Medicare claims specifically. They feel that would be very useful at the point of care for clinicians to augment any holes that they may have in the clinical information. So the whole idea is to allow for Medicare claims to be given to physicians at the point of care to help them make clinical decisions, know more about their patients, basically assist them in filling holes that they may have in the clinical picture for those patients.
And so the information that comes off those clinical claims, those Medicare claims, such things as diagnosis and procedures that have been performed, things like that, that type of data coming down?
That's part of it. They weren't real specific about what the claims data is going to include. I would assume it would include procedures that have been charged and billed to Medicare and diagnoses that go along with procedures or visits. I'm not so certain about medications or other things. Of course, there's other ways to get that. But I would think that the butter of it would be those types of information. One of the things that is a little gray is exactly what claims information they're going to start sharing. And therein lies some of the issues that concern me.
You know, something that just kind of pops in my head is that if someone has a diagnosis of hypertension or diabetes, that's not enough to tell us if it's under control or not. And so I don't know if there's some available coding for, within control or out of control chronic diseases. You would hope that a provider would really need the metadata to know what's going on beyond just a diagnosis, to know where they are within that diagnostic sphere. And was this a one-day presentation by CMS in D.C., Dr. Anders?
Yeah, it was just a very short presentation, actually.
Okay, and so it's something that kind of rolling out. I know for some time there's been a big push for maybe it started 3 or 4 years ago, the Blue Button Initiative, which is available to download a data file that would have some of this information in it. But actually, a Blue Button file may have more than is what is available in the Medicare claims data. I'm not sure, but this is all under really a subset of the whole issue of interoperability. Now, I can remember working at a pulmonary practice and the day that we got a fax machine. So I'm dating myself a little bit there. We got that fax machine, and we thought that was miraculous because we could get the primary care physician to fax over some office notes to us. So that was like stage one interoperability. We love that. So that was, to me, the beginning of the interoperability, and that's going back home 25 or 30 years from started using fax machines for interoperability. But the actual definition of interoperability and the different initiatives to bring that together, there's a lot of fuzziness there. And how would you define interoperability? Or as a provider, what type of interoperability would help you take care of your patients?
Well, actually that's fairly simple. I'm going to give you something, a phrase that I have given other folks in healthcare IT. Give me what I want to know when I want to know it without me telling you what it is. Mm-hmm. And let me define that just a little bit. What healthcare needs right now, I believe, at the provider level is not more data, it's more information. There are a lot of data points in an EMR as it exists today. And adding more data points going down the road, I'm not so certain is going to be helpful to a provider. And what I mean by that is, like I mentioned before, the type of claims data that Medicare is going to give us on each of our individual patients could be very little or it could be a lot. And being a general internist, some of my patients have literally tens of thousands of data points in their record.
Yep.
So the last thing I want to see is, okay, this claim is for, let's say, a postprandial blood sugar or a glucose tolerance test, coupled right next to it with the real replacement wheels on their wheelchair. As an internist, I don't need to see that. I mean, right. It's not going to help me when I've got 8 minutes with a patient in a room. So it's really the what and the how is the real problem with this kind of initiative. I applaud them as a first step. Yes, it'd be great to try to fill holes in a medical record, and that's what true interoperability does. But interoperability has several different moving parts. One, getting the data, being able to consume the data, and present it to the clinician at the point of care in a timely manner that they can actually take advantage of it and use it. So flooding a screen with another button where I go look at another screen that's got a whole list of codes, and that's the other kind of thing I tell folks is I didn't go to medical school to find a code. I went to medical school to treat patients. So if you give me something that doesn't help me treat my patients, I will most likely ignore it because I've got to get through my day and I've got to get through my patients, and we've got to make healthcare for that particular person better and get them in a more well state. So my concern is they've kind of put their toe in the water. They've kind of did a lot of buzz about this is really going to help without doing a lot of how and why.
You know, what I saw in my years working at a practice is a physician would get a referral letter from a primary care physician, and the first thing they would read would be the last paragraph, where the referring provider had really summarized, here's the issue, here's what I think's going on, here's a path I think is appropriate. And then they might skim over the earlier paragraphs or go to them for deeper information about every medicine they're on or things like that. And so, you know, if you're going to read one paragraph out of those out of the clinical encounter document, if you're going to do one, it'd always be the last paragraph because that was the summary. And so that, what you're saying is true is, you know, the need to triage all this electronic data that is coming downstream, and you know, it's all of the same font, it's all the same color. So, you know, which one to pay attention to? Yeah, one kind of side question to that is I've seen more and more providers, certainly still a minority though, who use scribes, so that they the culture of going in and seeing a patient, visiting with a patient, talking with a patient, the scribe is really handling the computer input. And so, do you see much use for scribes, or have you heard of much scribe activity going on in the ambulatory
there's a lot.
sphere?
Oh, yeah. Scribes have become very, very popular. And the reason scribes exist is because the EHR world as it exists today is not usable by a lot of physicians. They feel it gets in their way and slows them down, and they don't like it. So how do you not like something? I'm going to give that task to someone else. So I see a lot of that happening. What concerns me is we're not addressing the issue of usability of EMRs. That's number one. That's the reason scribes exist. Number two is if we build in, say this blue button or claims data comes in, the physician or the treating provider is going to have to see that. A scribe's not going to be able to translate it.
Yes.
And if you have alerts or warnings or interactions or other clinical decision support tools that are there being presented as you enter data, is the scribe going to say, pardon me, doctor,
Sure.
I got an alert here that says you need to do this person's mammogram. I mean, it puts a layer in there that concerns me as a clinician.
You know, you're talking about the usability of EHRs, and to me, that by itself is a fascinating subject. A lot of the technology tools we use on a daily basis, smartphones, some are more complicated than others, but there's some smartphones that come without even a manual on how to use them, because your first inclination, they're designed with their interface, so your first inclination is 80% accurate as to what to do. And the type of design that's being done as far as workflow through an EHR, things like that, could that just be tweaked up, or does it kind of all need to go back to to the beginning and redesign the process? One thing I always think about, because I was in the EHR implementation world for a few years, is that when computers came into the financial world, bankers didn't have to learn how to use them. The executives didn't have to learn how to use them. But when they came into the healthcare world, every provider had to learn how to use them. And so there was much more of a cultural shift there. And what can be done to make them more usable? Is it oral interfaces, or I don't know, what are your thoughts around that? Where are we in the design of the HR interfaces?
Well, it's a very interesting process that happened when EMR systems were developed, and I've helped develop several of them, and they all have the same issues because programmers usually are the ones that dictate the constraints here. But anyway, what I'm most concerned about is no clinician or very few clinicians ever get involved in the design of an EMR. It's like you're building a car, but you're not going to ask anyone who's going to drive this car.
Mm-hmm.
And it could be an elephant, it could be a leopard, it could be a human. But we're just going to build a car and hope everybody who needs or wants to use it is going to be able to fit behind whatever steering device we've created, and off it goes. The other thing that happens in a lot of the EMR design is these systems, for the most part, were designed to really execute a transaction. And what I mean by that, there's a visit, there's documentation on that visit, there's a code that gets spit out, there's a prescription that gets spit out. There's all the things that happen, but it's a transaction. The world of healthcare is moving into a more pay-for-performance or wellness model, meaning you're going to have to demonstrate that you actually are moving the bar in the group of patients that you're responsible for. And we have a lot of proxies for that now. All the MIPS, macro, quality measures, meaningful use quality measures are all a proxy for quality of healthcare. But the payment system now is shifting. meaning that Medicare Advantage, as an example, starts out, it was about 20% of Medicare a couple of years back, and they're predicting it to be 40% of Medicare by 2025.
Well, I had no idea.
And that is all based on performance, quality. Are your patient population and your patients getting better? And if not, why not? And if you notice the new recommendations for documentation that just came out, we used to count bullets. So many bullets for the subjective part, so many bullets for physical exams, so many bullets for decision-making and all of that.
For E&M coding? Yeah, for coding.
Right,
yeah.
For E&M coding. And they're going to ship that. The physical exam, the last thing I read about the changes, where they're considering the physical exam part of that, or the history, is as appropriate or clinically relevant. So that's going to kind of change the face of how EMRs are going to operate, because they were built to count bullets. Now we need EMRs that look and think like a physician thinks, saying, is this appropriate for a physical exam for this particular diagnosis? Or is my history appropriate? I'm really curious about how that's going to happen. And that's where the work I do now is geared towards that, is how do we make things clinically relevant at the point of care? And it's not an easy task.
Well, kind of back to the whole concept of interoperability, again, it's defined differently, but when we see it and it works, we like it. The providers I go to are university-based, and whether they go to the hospital or one of their outpatient clinics or have a procedure, they're all looking at the same EHR, and they all have the same view of me. And so that's pretty nice interoperability as long as I stay within that network. But globally across the country, it sounds like some of the plumbing and pipelines are in place for interoperability, but the content that's flowing through there, as you say, we're getting the wheat and the chaff frequently. There's sometimes redundant data that comes down in some of those interoperability files, those CCDA files. So it seems like we have the standards, but the culture of how to use those standards and only see what's relevant to be seen, that hopefully is going to be a challenge that's addressed over the next few years. I mean, this is certainly nothing that's going to be fixed in the next 2 or 3 years. This is a long-term process, big cultural shift that's going on. But and just ask you to look in the crystal ball a little bit. Where do you see us that we're in this trajectory of healthcare data interoperability? Are we halfway through this to where we want to go? Is it going to take 20 years to get there? What are your thoughts on that?
Boy, that's a tough question. That really is. It really, I guess, I will use my definition of interoperability, and I'll give you a little line about what that is. Mm-hmm. So as a provider, I want to be able to have Mrs. Jones in front of me, and I want to have a consolidated medication list, meaning no dupes, when things were prescribed, when they were last filled, things like that.
Yes.
A complete problem list of everyone she's seen.
Yep.
And all the metadata I can pull in as it's clinically relevant to those issues. So in their problems, have they had the appropriate testing? Are they on the appropriate medications? Are they clinically relevantly linked together? If I could get that, that would be interoperability to me.
I see. Sure.
And right now we have pipes in place, and I have to tell you there is a very few of those that work very well. State of Ohio is probably ahead of a lot of folks in the world of exchanging disparate data, but even they have a lot of issues in getting it piped in and piped out where it's supposed to go. So, I think we got some pipes in place. We've got a ways to go there. The actual filtering and giving clinical relevancy to the data that you get as a provider. There are tools out there now that are starting to be able to do that. I think it's going to take 10 more years before we actually get there.
I would think, you can see where we were 10 years ago and 5 years ago, and we know this is something that's that is worked out over a number of years. There's no doubt about it. Even to come up with new certification standards, that takes 3 or 4 years. So it certainly is. Well, some of the early attempts that I recall for networks of healthcare data were the RIOs, the Regional Health Information Organizations, and then that wave kind of went away, and then we had the HIEs, which I guess we kind of have now, Health Information Exchanges. And those RIOs seemed to me kind of collapsed because there was no underlying business reason or who would fund them or people didn't want to really exchange information. Are the HIEs the final word, or will there be, HIEs 2.0 that will gather all this data and, where it will go in and come out, as far as those large data networks? How do you see that playing out over the next few years?
Well, I think the HIEs are probably a model that has legs, meaning they have the ability to go in the future. They still have struggle with the business model for those too. These structures are not cheap, and it really depends on how they're funded and where they're funded. To me, the largest payer of healthcare in the United States is the federal government.
Yep. Mm-hmm.
And they have the ability to basically set standards, as they have, and set up regional HIEs that are federally funded and therefore subsidized. And I absolutely believe, that if Medicare wanted to improve the patient quality and outcomes of the Medicare population and thus everyone else, they would start to set these up, set the standards, set up a federally based HIE system, and it probably wouldn't be just one, it'd be regional or some other kind of spoke and wheel model of, but they have the ability to do that. And I think it would save them a lot of money if they would.
That's one thing I've often wondered. I can kind of guess why we don't have a national HIE. I imagine some of it's political, because there's the state boards of health and insurance, and Medicaid is kind of handled on a state-by-state basis. And so there's some probably cultural/political decision or leaning that's behind that. But one would think that really a national HIE, so you could be in California, but then if you were in North Carolina and need to see a physician, they could access your record. For so long, Social Security numbers cannot be used as a medical record number or identification thing for various political reasons, good or bad. So I don't know if we'll ever get that large HIE, but from a purely functionality and interoperability standpoint, to me, it's just obviously that would be the way to go.
I agree. I agree.
Yeah.
And if you want to get into a real spirited discussion, talk to people about the universal patient identifier.
Exactly. Well, I mean, isn't there federal law that says it cannot be Social Security number? I mean, there's federal law about that. Yeah. And so everybody's having to try and reverse engineer and figure out some way to identify patient, that this patient is not that patient. And it can get pretty complex trying to do that. So there's really technical and cultural things that are some of these giant challenges. We only have maybe about 2 or 3 more minutes here, and I want to touch on one other topic, if you don't mind. You mentioned the whole move from pay for performance to pay for value, especially on Medicare. And are the third-party payers, the Blue Cross and Blue Shields, are they going to be following that same path? Are they all just going to let Medicare do the downfill blocking and kind of shift over to that?
Well, history has shown us that whatever model Medicare starts to pick up and use, most of the private payers do too. And one of the things that we've already got in place are accountable care organizations, and they're primarily payer-based. So we've got a Medicare Advantage program that's growing, and I think the private payers are going to do the same thing because they're going to have the same reward. Patients get better quality. So I think they're going to follow suit.
I believe so. Yep, it looks like what's happening. I can't believe it, but the time has really flown by, Dr. Anders. So let me speak to our audience and just say thanks for joining me on this episode of the Tate Chronicles. And I offer a special salute to my guest today, Dr. Jay Anders of Medicomp. Dr. Anders, thanks for coming aboard today. We appreciate your time.
You're very welcome.
You can find more information on this show's program page at healthcarenowradio.com. And until we meet again, here's wishing you smooth sailing and safe harbors.
Tate Chronicles transmission ending now.